Well, good morning. I'm going to start right now. People will continue to join us at the beginning of the session, but welcome to Diagnostics for the Healthy, the Screening Paradox. We are thrilled to have you here this morning. This afternoon, and this evening. We have a large international crowd. And my name is Mara Aspinall. I'm a professor of practice at Arizona State University in the College of Health Solutions in the Biomedical Diagnostics program. Just to make you aware, you should have gotten this as you came in, is that this event may be live streamed, photographs, or indeed is recorded. We are thrilled to be part of the College of Health Solutions, where better health outcomes require better solutions. We understand that, we know that, and one of the key pieces of better solutions is truly through diagnostics and our biomedical diagnostics program. But today, this is the beginning of our national and international diagnostics educational webinar, and it is brought to us today in cooperation with Thermo Fisher Scientific. It is wonderful to work with the team at Thermo Fisher Scientific, and we appreciate their cooperation in making this program happen. Today is pretty unique because for our discussion, we have brought to you academia, industry, and government. We have three fantastic speakers, and we're going to discuss the positives and negatives of screening, as we call it the screening paradox. So whether you think about screening as very impactful and creating actionable decisions, or expensive and creating uncertainty, we're going to look at what that means for the general public, and happy to answer any of your questions. We'll start with introductions of our speakers, and then we will move to a discussion that I will moderate, but we will very much open it up to questions from our audience. As you can see, we are running this in a meeting format, so all of you should be on camera if you are comfortable doing so, but please, I would ask you to mute so we can make sure we hear our speakers. If you have questions, please put them in the chat, and we will take as many questions as possible, and we will end at the top of the next hour. So with that, let me welcome our great speakers, and I'm going to let them introduce themselves, but I'm going to give you a little bit of background, and then I'm going to do some level setting. Our speakers are Karen Anderson, who is both an ASU professor and a medical oncologist, associate professor of medicine at Mayo Clinic, and she is very much focused on the immune system and detecting and altering cancer development. Our next speaker is Tina Clark-Durr, vice president of epidemiology and distinguished scientist at GRAIL, and she has dedicated her professional career to reducing the burden of cancer through prevention, early detection, and population health. And then Bruce Tromberg. Bruce is the director of the National Institute of Biomedical Imaging and Bioengineering at the National Institute of Health. He led what's often called RADx, the Rapid Acceleration of Diagnostics Program, a $1.7 billion initiative that most recently was focused on increasing COVID testing capacity and performance. All of our speakers are great speakers and very well read and authored publications in the field. But as we start, let me just give you a little bit of context, and then I'm going to hand it over to our speakers. What are we talking about today? Screening. How do we define that? Identifying unrecognized disease with tests, exams, and other diagnostic procedures. Screening sorts out those who are apparently well, who probably have a disease, from those who probably do not. A screening test is not intended to be diagnostic, and follow-up is needed. When we talk about screening today, it's a broad range of technologies, from blood tests to imaging to your smartwatch to psychological screening to liquid biopsy. It's not about any one technology. The purpose of screening, very clear. Identify risk for disease in a non-symptomatic state when action, prevention, and/or treatment may be possible. I'm not going to go through the history history of screening, too long to list, but just a couple of key dates. Many would say that screening started with the U.S. Army and psychological exams to get into the Army for World War I in 1917. The 1940s brought screening for cervical cancer through the pap smear and diabetes. 1960s newborn screening, 1970s breast cancer, 1990s prostate and colorectal cancer. And what you'll hear today is some of those screens have very much changed with the knowledge that we have today. But a key date is 1984, when the U.S. Preventative Services Task Force was established. And today, it continues to be the most influential body in recommending screening in the U.S. But we're not going to just talk about any one screening. We're going to talk more broadly about what is screening today, how has it changed, and how should it change going forward. So with that, let me hand it over to our first speaker. And Karen, let me focus on you and your definition of screening. Do you see it the same way that I had discussed in terms of screening today?
So I absolutely agree. You know, traditionally, as we've thought about screening, and I focus a lot on cancer screening, that's our background, has been on imaging modalities, for example, mammography screening, molecular diagnostics, and some of the early ones in PSA or CA-125. But certainly, as our technologies are rapidly improving around us, the concept of screening, obviously, it encompasses many other types of molecular diagnostic modalities. And now we're getting into, as you said, into smartphones and others. And then this is sort of merging in many ways with these emerging definitions of risk, right? Whether they're coming from genetic risk, from polymorphisms or familial history, to whole genome sequencing and other approaches to identifying genetic risk. But again, we have physiologic risk, we have psychologic risk, we have others that impact this. And so we are starting to develop all of these tools for evaluating health. And when does it deviate from health, within a person and between a person and within a population? And how do we evaluate these changes from a health norm and put that into a clinical context and into a healthcare context? I think that's going to be, the challenge certainly over the next decade of as we get better at measuring all of these different differences.
So Karen, that's very helpful to understand that context, particularly in light of the fact that there are different risks. But we often hear about the value of biomarkers. And is there a one-to-one relationship? Maybe Karen, you can start here and then we'll go to our other panelists. Do we always know the biomarker that defines risk for screening?
Well, so when we think, biomarkers, for example, the challenge is, if you have a biomarker and you have a test, first of all, no biomarkers are perfect. There are false negative rates and false positive rates. And so if you put that in the context of screening healthy individuals, whether it's general population or individuals at increased risk, you will always have some component of false positive or false negative situations. And so then what do you do with that information? Okay, think about this in the context of ovarian cancer screening. What do you do with information of elevated biomarkers? The UK CTOX program in the UK for targeted ovarian cancer screening, identified this. Well, if you have rising CA-125 or alterations in these different biomarkers, you then have to deal with the consequence of those tests, and that those consequences may be it leads to another test. That consequence may be it leads to different imaging modalities or different physical exams or other things, or that consequence may be surgical intervention, depending on what the screening modality is and what that can be. So all development of molecular diagnostics has to be within the clinical context of, what is the risk population that we're thinking about, and then what are the downstream effects of those molecular tests, those imaging tests, those physiologic tests for evaluating somebody, and do we have the healthcare systems and the processes in place to be able to deal with the consequences of positive tests.
So I appreciate that. So let me go to Bruce and let you introduce yourself. So sorry about that. And give us a little bit more context, because you've seen so many different technologies used for screening. So how do you see it today and this impact of screening using different modalities?
Yeah, thanks, Mara. And thanks for organizing this and for inviting me. And I think you gave a great introduction for me, but just to put a little more emphasis on it, at the NIBIB, we support technology development across all different modalities: hard materials engineering, soft materials, big physics, small physics. So we see screening maybe in a little bit of a different context. But I think Karen brought up some really important points, excuse me, about really understanding how a particular test should be applied. And a lot of our insights can be derived from the performance of the test. So oftentimes diagnostic tests and screening tests are kind of used interchangeably. And we saw in the pandemic where some of this can create problems. So for example, early on, in particular in the pandemic, relatively poor performing antigen tests were used to screen asymptomatic individuals. And it really took a while for people to understand what the performance limitations were. And that was probably an inappropriate application, that the best test for screening would have better performance. You need to have the pretest probability of a result really better understood in order to apply these effectively. So that's if you take one test in isolation and you want to minimize the false positives and the false negatives, depending upon what particular disease or condition you're applying them to. But another really important point that Karen brought up is there's more than one test. Like a single test is not the screening approach. So it should be an integrated and thoughtful approach to screening. And we often use tests that are able to measure emergent properties. So rather than zeroing in on like a single molecule or a single mutation, we can look at much, much more. And classic examples are blood pressure, heart rate variability. These are relatively easily accessible and emergent properties that are kind of well understood from a screening point of view, but they can be better. And part of this is really figuring out the interval for screening. So how often do you do these? Do you do single snapshots? If I do my blood pressure once a month, is that an accurate reflection of whether I have hypertension or I'm at risk? So we can, from a technology point of view, begin to push these to more continuous scales so we can see the impact of circadian biology on many of these emergent properties, and then measure in the context of the timescale of the biologic process that's relevant. So these are new things that are increasingly available from a tech point of view, and figuring out how to integrate those with our single snapshot tests, our molecular tests, our imaging approaches is really the main challenge. I don't think we have many, many technologies that are incredible and moving very quickly, but thinking about how to integrate them and take that information across these scales, both molecular and spatial scales, but temporal scales as well, is really a key challenge.
Thank you, Bruce, for that. And you do bring up an interesting point about technology integration and temporal scales in terms of what does screening look like over time. But let's stay on that issue of new technologies. One of the newest technologies in screening is called liquid biopsies. And one of the companies that's at the absolute forefront of that is Grail. So we're very pleased to have Tina Clark-Durr with us. Tina, can you introduce yourself and give us your context on screening, and in particular, how you think about the world of liquid biopsy today?
Absolutely. Good morning, everybody. My name is Tina Clark-Durr. I'm the Vice President of Epidemiology at Grail. And thank you for the intro to our company. Grail is based in Menlo Park, California, and we have developed a test. It's probably one of the newest innovations in screening, as you pointed out, Mara. There haven't been a lot of innovations in cancer screening in the last few decades, but we have, and I'll kind of give you the background and history of our test, but we've developed a blood test for early cancer detection. We call it multi-cancer early detection. Our test takes a single blood draw, and it basically analyzes all of the cell-free DNA floating around in anybody's blood sample. It sequences all of it and looks for a targeted methylation pattern that was trained on a machine-learned algorithm. And it tells you if we detect a cancer signal, and if so, where that cancer signal might be coming from. And that allows a physician, this test is only available through prescription from a physician, to work up a patient with a positive signal for cancer with traditional imaging or other workup as required to identify a cancer at early stage. Our test is designed to be used as a complement to guideline-based screening, and we are about 7 years into our development. We've launched the test commercially and have a large randomized controlled trial running in the UK with 140,000 participants to understand if it reduces the incidence of late-stage cancer in that National Health Service population. So it's a super exciting technology. I think this is really timely for students to be talking and thinking about screening, because the genomic revolution, the cost of sequencing at this scale is going to enable many other tests that are designed to detect cancer or other diseases in individuals who don't have symptoms or who otherwise are not in the traditional diagnostic stream yet. So I think this is a really timely conversation. And I guess the other thing I would point out about cancer screening that others might not have covered is the enormous unmet need for earlier detection. Cancer is the #1 cause of death in many populations in the US that have reduced their smoking rates down below 10%. Heart disease treatment has become successful in many populations, and that pushes cancer to the #1 cause of mortality. We currently screen for 4 cancer types only, so breast and cervical in women, and lung cancer in high-risk individuals, and colorectal cancer in men and women. So if you're a non-smoking man in this country, the guidelines say that you should be screened for exactly 1 cancer, which is colorectal cancer, starting at age 45. So that covers about, conservatively covers about 30% of all cancer deaths, leaving 70% of all cancer deaths caused by types that have no way to diagnose them early. So we see a huge unmet need for new technologies, be it ours or any others, to find and detect cancers early.
Really, really helpful. Tina, thank you for that. And I'll emphasize that it's become a very big industry with 4 companies now having different types of liquid biopsy tests. And one of the, potential for here is that it's just a blood test as opposed to a traditional biopsy. So less invasive for all 4 of the companies in this space. But let's take it back a bit and talk about the value of screening. And when we talk about that, and there's a lot of focus on cancer, but let me ask each of our panelists, what is the value? What we hear a lot is, what is the value of screening when you might find out the disease can't be treated? And therefore there's nothing that can be done to improve the health of the individual person. Bruce, I'm going to start with you here and then go to Karen. That's a lot of the controversy here. Why do I need to be screened if I'm going to find an answer that says I can't be helped? How do you think about that?
Well, okay, I'm biased. I'm a technology person, so I think it has enormous value. Both for generating information content that can potentially be actionable at some point in the future, But, we can think of some classic example of that, and that's looking at ApoE variants and haplotypes. So you may have a variant or haplotype that is suggestive of a higher risk of Alzheimer's disease, cardiovascular disease, diabetes, and so forth. Not all of those will be treatable, particularly Alzheimer's disease, but there may be lifestyle interventions or changes or optimizations you can do to minimize your risk for developing full-scale disease. We don't know what all these interventions are. So even in the absence of a specific molecular or chemotherapy, it really makes a lot of sense to me to try to develop as many of these as possible. I won't answer the cost effectiveness question, but I think cost effectiveness is another issue altogether, because as a nation, we're doing very poorly in terms of expenditures per capita and life expectancy with respect to our peer nations. There's really a huge disparity there. And I don't think it's necessarily the costs of all of the available diagnostics or therapeutic approaches. It's not a very well understood integration of the opportunities that we do have across all these scales, and giving access to all populations. So there's less disparity in our approach with these technologies.
Very helpful, and I love the technology focus. Let's shift to the academic, but very much clinical focus. Karen, with you, you must get that question a lot from patients. Why do I need to be screened if there's nothing I can do?
I absolutely agree with Bruce's comment. Well, there's nothing we can do today, perhaps. But tomorrow we don't know what that change will affect. And I think that in many ways, knowledge is power. And does it change whether it's lifestyle modifications or whether it's more precision screening, for example, down the line? But if you're diagnosed with something today that may not be treatable, the question is, does that impact other aspects, psychological or other aspects, and does that impact potentially knowing and being able to participate in clinical studies and targeted clinical studies to advance the field and perhaps change that? I mean, we have seen a tremendous change in molecular targeted therapeutics, for example, over the last 20 years. I've seen this in the field of breast cancer. And the pace of this is only increasing. So there is a shift in what we're doing. Look, we dealt with this with HIV diagnostics back in the 1980s.
Mm-hmm.
Why know if I have a virus if it's not going to impact my own health? Now, in the context of infectious diseases, that's a different story, because you can impact population health, obviously, by understanding that. But even in the absence of infectious disease, that's why understand this. Well, it can change information, and that information can then lead to different therapeutics and our understandings of this. I think I want to get to this the concept also about kinetics and pace that Bruce brought up, that measuring things over time and the advantage of doing that, whether or not that's a molecular diagnostic marker that's changing over time, or whether or not that's an individual at rising or increasing risk of a given disease. I think that in the context of breast cancer, in mammography screening, we have certain time intervals in which that imaging can be done. These are snapshot tests, but the rapidly proliferative breast cancers the majority of those are diagnosed as interval cancers, as the ones that are presenting in between regular mammography screening, even for people who are undergoing recommended interval screening for breast cancer. And this is one of the challenges that we have. We need, whether it's molecular tests or imaging tests or AI generated physiologic monitoring, whatever that may be, we need them to focus on in particular in the cancer field, on the ones that have impact on mortality, the rapidly proliferative tumors, the high-grade tumors. And these are the ones that are really difficult to do, and that perhaps may need more frequent evaluation in order to be able to detect them early enough to have a stage shift. early enough to change the impact on both morbidity and mortality. How much therapy is needed? What are the rates of doing this? And so how do we identify those cancers in particular, rather than the slower proliferative ones that we identify but can be done in snapshot tests?
So if I take that, I'm going to take it to Tina and continue to add to this. And Tina, I'm going to make it a little tougher for you because, in the sense that that is one of the criticisms of all the liquid biopsy tests, which is, are there going to be, is there anything that's going to be useful for me as an individual? And I like the idea of research. I want to know what's going to help me. And then secondly, this issue of false positives on some of these new technology tests. Are they going to create anxiety when I might not have cancer? So how do you see this? And, adding to Karen's perspective and Bruce's perspective here.
I'm going to focus in on cancer just because that's what I work on, what I've worked on my entire career, as you pointed out, and talk a little bit about cancer and why we think early diagnosis is so important. So when we screen someone, an asymptomatic person, for cancer with any test, what we're saying is, you need to be worked up. This is not a diagnostic test. We're saying you need to have additional workup, including, gold standard biopsy for invasive cancer that would lead to an intervention. We know from our population-based cancer statistics that when we catch and diagnose a cancer at a localized stage before it has spread beyond the organ that it originated in, that survival outcomes are vastly superior to detecting a cancer at stage 4 or after it has metastasized beyond the organ that it originated in to other parts of the body. The average statistics across all cancers combined in the US for those two situations are about 89% 5-year survival versus 21%. So there's a huge survival difference. And that is because for most solid tumors that arise in organs that can be surgically resected, when the cancer has not spread, treatment is much more effective. The treatments that have been developed, including surgery, chemo, and radiation, are just more effective when they can, cut the entire tumor out and not after that tumor has metastasized to the brain, liver, or other parts of the body. In fact, in many situations with stage 4 cancer, as people probably know, we don't give treatment because the outcome is so dire. So for cancer, we see a huge opportunity to shift the stage distribution earlier for many cancer types. That's not to say that there isn't controversy, and some people will say, okay, for pancreatic cancer, which has very poor survival, no matter what stage it's diagnosed at, we're not sure that screening for that particular cancer is going to result in a survival improvement or a reduction in mortality. Our test is really interesting and different because, again, we're looking for this signal, this genomic signal shed by any cancer, that many copies of mutated DNA that is, measured by our next generation sequencing based blood test that would very strongly suggest the presence of a tumor. So it's not saying anything about risk. It's not saying anything about the far future. It's saying right now we're looking at the pattern of your cell-free DNA and we see something that needs additional workup. So, and one really important feature about our approach and our test that is very different from previous technologies, which people know, mammography is, an X-ray of your breast tissue, basically, and colonoscopy is also direct visualization of your colon through a scope. The false positive rate is just much, much lower. We've gotten our specificity of our test down to 99.6%. That gives us about a 0.4% false positive rate, which is much lower than, for example, an 11% false positive rate we see in mammography. So these new technologies are just really, really different. But some of the essential tenets of screening we've talked about in previous parts of the discussion today, we are looking for a signal that would suggest additional workup, which is more invasive. So we're not exposing people to the invasive biopsies or what have you until we have imaging or other excellent reason to do so. And with these newer technologies, one of the huge benefits for population screening is that the false positive rates are just much, much lower with these different technologies.
So thank you, Tina, for that. We'll come back to that because I know that there are a number of questions here, but let's mix it up a bit. Instead of just having my questions, I'd like to introduce some audience questions. And let me say, for those of you in the audience, please put your question in the chat, address it to anyone, the web technical director, or to me. So our first question came in from Kathy O. Thank you, Kathy. And the question is, people are often given drugs which are either too strong in dosage or incompatible with their personal genomic or other profile. Do you believe there will ever be a screening test which will accurately profile and individualize drug dosage so that appropriate and effective drugs can be given? Not just chemotherapy, anesthesia, painkillers, anxiety drugs. Can they be contoured specifically to people as an individual? A very hot topic in terms of screening. Bruce, I'm going to send it over to you first.
Okay, thanks, Mara. Of course, you're going to get the optimistic technical view on this, but I can tell you a lot of this has been led by cancer, where, we're hopeful to have personalized precision therapies. And one of the ways to do that is to build what are called microphysiologic systems. So systems on chips using bioengineering approaches that actually recapitulate the tumor and its microenvironment. And so initially these have been used to assess for individuals whether or not they might be responsive to various chemotherapeutic approaches. This is extended in our field to looking at multiple organ systems, including microvasculature connections. So being able to, in a sense, have an avatar of yourself on a chip, recapitulate multiple processes, and you could then, in theory, look and see what the potential side effects of medications are and begin to optimize dose. When you combine that with better diagnostic approaches that can assess the impact on related organ systems and on the direct target, I think this is possible. So a combination of bioengineering approaches and improved assay-based technologies.
So thank you, Bruce, for that. And it's a great justification and with Kathy's question as to why these are important. I guess I'll leave it as an open question. Anyone wants to answer it. But why have these tests not been successful to date? We've had so many, I count it, we're in the 4th generation of pharmacogenetic tests. And either payers aren't paying for them, doctors are not using them. I see Karen nodding there. So Karen, I'll send it over to you. Why do you think these tests, and we have a lot of labs on the line, have been running these tests very effectively? Why have they not been adopted?
Well, I might show as an example 2 different hormonal therapies that are used routinely in breast cancer management. So one is tamoxifen, okay, a anti-estrogen therapy. And tamoxifen is metabolized in a certain way, and there's about 7% of the population that metabolize tamoxifen differently through an enzyme called CYP2D6, CYP2D6. So we routinely do pharmacogenomic analyses to assess whether or not a woman can metabolize tamoxifen to its active metabolite and use that to do precision therapeutic management. And I would say that is one example in which we do this, but that's not universally done. And there is significant controversy as to the utility of that test and the reimbursements of those tests, et cetera. I think also for tamoxifen use, we're learning that doses may be different, that we can decrease doses in different clinical settings, such as the prevention setting, where maybe we don't need full doses to have the same impact of preventing cancer management. And so that decreases side effects and toxicities of therapy. And then on the flip side of that is aromatase inhibitors. Again, therapies that are used throughout the breast cancer management for hormone receptor positive breast cancer. There, the doses are one size fits all. We have one dose for women, no matter what size that they are, and are we effectively inhibiting those aromatase inhibitors, et cetera, in that setting? So I would say that we use pharmacogenomic testing very little in sort of in a routine healthcare setting. I think that there is large opportunity to change that. And I think that that may give us that more precision therapy. But getting to Bruce's point about these avatars, right? We right now, for cancer management in the advanced cancer setting, other than precision management based on genetics of a tumor or protein expression of a tumor to perhaps give more precise measurement, otherwise, there is a tremendous amount of trial and error. These studies have said this, and so we start with this drug and we see if it works, and we start with this drug and see if it works. It is slow, it is ineffective. You want to provide more precision targeted therapeutics, and I think any method, whether it's more physiologic or more technical, that improves the precision of our therapeutics and being able to target those would really advance the pace of therapeutic management.
Yeah, I have to just say this, Karen, because for so many years I've been saying trial and error medicine only works if you're learning something. Yes. And then can personalize it. We can't say you'll never do trial and error, because by definition, that's the way you learn. But it can't be trial and error forever. So excuse me, taking the moderator's prerogative there and adding some commentary. We have some more great questions. So I'm going to turn to Michael Donovan. Michael, can you ask your question? And then Martin Ramirez right after that.
Sure. Thanks, Mara. I want to hear the panel's thoughts and in terms of how this can be addressed. And I guess this is a screening issue, but it's also a diagnostic issue and a kind of an overarching issue in terms of data. Is the role of race and genetic heritage in screening, where we're starting to see that so much of the data used to develop screening tests as well as diagnostics has been based on information from those of a European heritage, and now you're seeing that maybe that doesn't hold up for those of diverse backgrounds. I mean, do you see kind of an individualized, or at least an individualized screening methodology, or how does this get addressed in the future?
Mara, do you want me to
take that? Yeah, can you take it first?
Sure, I can just jump in with a specific example. I don't know if you're following, and probably Karen and Tina are following this. Just at the recent ASCO meeting, I think that there were some results of the FANS study, the female Asian non-smoker study for CT screening and lung cancer. And so there is, understood potentially a higher prevalence rate of lung cancer in that population. This is a population in the US. And what was astounding in this CT screening study using low dose CT, an incidence rate of about 2.5% was found in that population. Now, in invasive lung cancer, it was 1.5%, but that was of all lung cancers. So for invasive disease, it was 1.5%, still quite astounding. Now, there are features, qualities that population has in common with others, but that was, in a sense, the easiest way to do risk stratification based on a history of observational studies. And this is our big challenge, is how do we better do risk stratification from a molecular, genetic, epigenetic point of view, the impact of the environment or the exposome on populations, particularly in cancer. So how do we integrate across all of these different scales? We certainly see superficially that there are segmentations and different incidence rates of disease in different populations, but we need to go deeper and understand those better, which of course means we need to diversify the populations that are in our studies in the first place and begin to move away from these large statistically based approaches, which of course are necessary in order to make evidence-based conclusion about how therapies will be delivered. But there's a lot of information in the individuals, and getting to longitudinal measurements can help unlock that. Looking at outliers in response will help unlock that as well. So I think that FANS study is really quite interesting and kind of a strong motivating example for what you've suggested.
Thank you, Bruce, for that. And we'd love to keep this conversation going. So if you send us the link for there, anyone who wants it will make sure that that's available to read more about that study. So let me now go to Martin Ramirez. Martin, do you want to ask your question live?
Hi, yes. Well, I think Christina, Tina already answered this. My big question, whenever I hear about screening for cancer among the healthy, I'm reminded of my aunt, who, after 84 years being on this earth, she developed inflammatory breast cancer, and over the course of 4 months, which is shorter than the interval dictated by Medicare or any other private insurer, had developed full IBC. And I don't know if there's anything that could have helped her, but what I'm kind of thinking about is that these liquid biopsies, could they help? And it looks like Tina says that they've already gathered data to be able to shorten that interval, especially for some high-risk populations, so that we could actually get quicker access to treatment for those who don't have palpable breast cancer, in other words, tumors, and also lung cancer as well.
Thank you, Martin. And I know, Tina, you answered in the chat around screening intervals. You see that as approximately a year. And obviously one of the questions that comes up is affordability. But is that the way you think we're gonna go forward? And then I'm gonna shift from there to the new breast cancer guidelines, because ASCO has changed those recently. And over to Karen. Christina?
Yeah, no, so let me just talk a little bit about how, if one was able to, proactively design a screening program to detect a particular disease early, the kind of considerations you would want to know about that disease in the population would be the prevalence of that condition in the population. So for our test, we look at the incidence of all cancer combined, which on average in persons aged 50 to 79 is about 1.3% per year, saying 1.3% of people will develop any cancer between the ages of 50 to 79. And each annual year. Obviously that increases rapidly with age. So it's much, much higher in your 70s than it is in your 50s, but we're trying to develop a program. So thinking about, what is that condition? Do I think I can intervene? We've already talked about, surgically resecting tumors if we can catch them early enough. And then, right, how often would I need to screen people in order to catch them at that early stage? And then those are the benefits. And then you got to consider the harms. So the harms would be when I screen a healthy person and give them a false positive and they have to be subjected to a diagnostic workup that was unnecessary. That workup could involve, for example, a colonoscopy has risks of a perforated colon, so you have to kind of factor in what are the harms and what are the benefits. And really the best way to understand that would be to run a clinical trial and to be able to measure in your target population, what are those, what benefits and what harms did we see? And that will inform the screening interval. And then you can put some economics onto that and understand what are you getting for your screening program.
So very helpful, Tina. And let me hand it over to Travis, and I want to talk to Karen about the new guidelines. Travis Schlappe, you had a question about this issue of false positives in screening, which is typically the biggest question, the biggest negative, other than cost that's discussed. Travis?
Yes, my question is very related to what you were talking about, Tina, the risks and the benefits of screening. My question is a little more quantitative and kind of for Bruce and Karen. Is there a number you guys are looking for? So Tina said they have a 99.6 specificity, 0.4% false positive. So if we were to screen everyone, 100 million people in the US, for example, I guess that's not everyone, that'd be 400,000 people clogging up the US healthcare system and having the downsides of the false positives. And the benefit is you catch whatever numbers Tina said, 500,000, 1 million people that do have cancer. Do you guys have a guiding number about, do you want 99.9% specificity? Is 99.6 good enough to recommend screening for everyone? Or where do you draw the line, or is it you have to do a clinical trial for every single case, kind of like Tina was saying, and do an economic study of everything?
Who wants to take that first?
I can give a short answer and then pass it on. But, in general, yeah, every case has to be evaluated. The performance of the test has to be considered carefully in the context of the prevalence. So you have to evaluate the pretest probability, and then you have to do your cost benefit analysis of the false positives. And again, I would hearken back to the early days of COVID, where people were really worried about false positives. That was the major discussion going on. And it was clearly because of the performance limitations of the test, the actual limits of detection of many of those tests were really unable to pick out COVID from a large screening population. And we saw deployment at scale that really was totally unprecedented. Now, the fact that the tests were relatively inexpensive on a per test or per capita basis really helped drive the motivation for expanding their use in a screening type of format. But as we better understood the performance of the test, then we could give guidance on its appropriate utilization to risk stratify individuals who would take those rapid antigen tests and say, okay, it's better if you have symptoms. And then if you get a negative test, to avoid a false negative, do it again on the time scale of the biology of the process of the disease. Now, in an infectious disease, that time interval is a few days. So it was about 4 days, 3 days, pretty well understood. So people were then we asked people to repeat those tests. And I think that's a paradigmatic example of how you can extend that way of thinking to other diseases, other rates of prevalence, and understand the cost benefit ratio.
Super. Any additional comments on that?
Yeah,
So
I might add in the consequence of a false positive test. It is in the context of what are the next steps. So if there is a good imaging modality for localization, and if there is relative ease of biopsy. So for example, if the consequence of a false positive test in breast cancer is that you get a mammogram with an 87% or so, sensitivity rate, and it is localizing, and maybe there's a consequence of getting a breast biopsy versus having a ovarian cancer test, where the consequence is a transvaginal ultrasound with only 20% sensitivity, and a clinical consequence of surgical management and prophylactic oophorectomy, or fallopian tube resection. These are very different consequences. So as we think about what is acceptable for a false positive rate, it depends. Is this a healthy population? Is this a clinical setting in which this just leads to another test, perhaps with low morbidity and mortality or low cost? Then that's a different story to something that is where there's limited secondary screening opportunities and it's much more invasive, such as a lung biopsy or others. So there's no one level, but certainly the healthier the population you get, certainly the higher the specificity that the test requires in order to be able to screen larger numbers of people.
So Karen, let's stay with you, and we've got 8 minutes left. So we're going to ask you one question, then we're going to do the lightning round with our 3 speakers. Karen, very recently, the breast cancer screening recommendations have changed. Can you give us a quick overview of that, what you believe, and when they start to take effect?
Well, you know, the prior screening recommendations from the U.S. Preventative Task Force were to start breast cancer screening at age 50, but to have a conversation with your healthcare provider between the ages of 40 and 50. And so that window of time between ages and 40 and 50 have always been somewhat controversial. And I think there was a lot of discordance between recommendations for screening in different regions, whether the American Cancer Society, ASCO, others. And many clinical settings still did routine screening starting at age 40, or in terms of those recommendations. There is a mortality benefit from age 40 up. The problem is the younger you get, both the rates go down in terms of breast cancer incidence, but also that the efficiency and effectiveness of mammography screening also decreases. So I think what we really need is better molecular tests and better approaches for young women who are developing breast cancer, and those are the approaches. And I think right now, though, that those screening recommendations are at least shifting younger. We're also seeing this obviously in colorectal cancer as well, for the screening shift for colorectal screening. But I think the other thing with the guidelines, and this was brought up earlier, is when do we stop screening? When do we recommend stopping screening? And I don't think that we have, you know, the ability to do firm guidelines on this, because we have such a tremendous variation in health, you know, in our 70s and 80s, and our life expectancies depending on other comorbidities. And I think clinicians factor that in when it comes to, you know, when to stop, you know, routine screening for lower risk cancers, for example. And I think those end up being very personalized decisions and discussions with patients.
Super. So thank you for that. And I'm going to take off from there. One really tough question, and I think an easy question for our lightning round. So first question is, who decides who gets screened? Should it be population algorithms, personal choice? Does it always have to be a physician who writes the script for a screen? What do you see as the ideal state for the future? Karen, I'm going to start with you. Questions.
Well, I think that we do need to provide screening guidelines, but ultimately the decisions about screening, you know, rely on autonomy and the opportunity, and I think it is very incumbent on us to have access to screening modalities. You know, the screening, you can have the great screening test, but if it's not getting to individuals, and if they're not able to do it, then it's not that useful. So I think that we need to, you know, improve access to care, improve access to screening opportunities in particular, to be able to do this. And it does involve discussions. I think minimal risk things such as blood tests, there are certain areas that where you have the right to do this without a prescription if needed, and Arizona is one of those states.
Yeah.
I personally am completely in favor of that, but I think that there needs to be, you know, downstream access to the, you know, for a positive test.
Tina?
It's a tough one. I mean, for cancer screening, a positive test means you need immediate medical attention. You need to get yourself imaged, or you need to get that diagnostic workup going as quickly as possible. So I would hesitate to say that you should be able to access these tests online or on yourself without making sure that you have access to that diagnostic workup. So tricky question. And I know things have really changed in the kind of post-COVID telemedicine era. So I think these are really, really important questions, but I guess I would tie it immediately to, you know, a positive test needing immediate medical attention. I would point out,
it's
yeah,
is all about a screen and then a diagnostic if positive, because that's certainly not useful without that. It just brings anxiety.
I would point out this is an America unique question, because in a national health service, we feel confident that people have access to care, but that's not necessarily the case here in the US.
Very much so. Bruce?
Yeah, I agree with what both Karen and Tina pointed out. I think those are really critical concepts. And I would just add that existential risk from whatever it is changes over time. So the idea of screening will significantly change over time, and it's really hard for the general population to interpret that. So I think we need to do a better job of educating healthcare and kind of changing culture just a little bit in this to make things better understood of the intervals and the type of technologies that we use at different stages or phases in our life. You know, we pointed out the case of breast cancer in a chronologically older individual who, you know, we now have the capacity with epigenetic approaches and the Horvath clock, for example, to be able to get actual biologic age, which may be a better predictor of risk. And, you know, that's another potential screening approach, looking at those epigenetic clocks. But overall, you know, I think this is something that people need to have some control over. And you see with the emergence of digital health approaches and wearable technologies, there's this enormously expanding industry that is just saying, you know, we don't need regulatory authorization. We want to just go straight to consumers and straight to those markets. And what seemed like science fiction maybe a few years ago is now a commonplace reality as individuals follow those dynamic measurements and, you know, follow their sleep, which is a screening type of approach, look at heart rate and heart rate variability. So these have expanded in use, and, you know, to a large extent, these are not FDA cleared or authorized tests. So we on the medicine side need to kind of get on board and be able to figure out how to really provide really good guidance and optimize the technologies and the performance for many of these, some of which look very much like what you might get in a hospital, but they are consumer-based devices. So this is a really big new frontier.
So with that, I'm going to summarize, and I'm going to summarize in one way and thank our three fantastic panelists. And we could continue for hours here. I'm going to summarize by saying we need more education for the lay public, for physicians, for providers, for insurance companies, and even for government to understand the basis of screening and how we go forward. Let me thank our great panelists, Dr. Karen Anderson, Christina Tina Clark-Durr, and Bruce Tromberg. Thank you so much for a great session and some really provocative areas. Bruce, if you could add maybe the Horvath test in the chat so people understand what that is and biological epigenetic age. And I would encourage everybody to go there to see the links. Thank you on behalf of the ASU College of Health Solutions and, very importantly, Thermo Fisher Scientific. I am very pleased to say in our cooperation with Thermo Fisher Scientific, we have 2 more upcoming sessions: technology, diagnostics technology in the post-COVID lab, and diagnostics, what do healthcare providers know or should know in the future. At ASU, we will also have our annual summit, which is October 19th. You'll all get an invitation to that, as well as our 2 additional educational sessions with Thermo Fisher. So let me just thank all of you and really appreciate the opportunity to be working together and to continue this discussion in terms of the strength and the power of diagnostics and to use it well. Look forward to seeing you at another session. Stay well, everyone. Bye.